Onc Live Insights is a video editorial program produced by Onc Live.
In addition to looking at things like progression-free survival, overall survival, Lux-Lung 3 and Lux-Lung 6 looked at patient-reported outcomes. You know, I think it's so important in our research in this day and age to include patient-reported outcomes and really see not only does the physician say this patient is having diarrhea and that patient is having rash, but how do the patients feel about their symptoms? How does it impact their life and their quality of life? Because this is what is really important for our patients who are being treated with these drugs. And so there were pretty extensive questionnaires included in the Lux-Lung 3 and Lux-Lung 6 studies, and the bottom line is that they showed that the patients on the afatinib arm compared to the chemotherapy arm did have a more rapid and a deeper improvement in some of their cancer-related symptoms, things like cough and shortness of breath and pain in the chest. Also, they showed an overall global improvement in quality of life that was more dramatic for the EGFR treatment, the afatinib, compared to the chemotherapy. Some of the other studies that have looked at an EGFR treatment compared to chemotherapy have seen similar things. So I think that the take-home message about patient-reported outcomes is that if you can give a patient a targeted therapy that matches the mutation in their cancer, in general, it is a very good thing for quality of life because it has such a strong effect on their cancer and because oftentimes the side effects of these targeted therapies are more mild than some of our other types of treatments.
So the TKIs have a very unique set of side effects. Unlike standard chemotherapy, we don't see hair loss, we don't see compromise in blood counts, we don't see very much in the way of upper GI toxicity, nausea, vomiting. There are two critical parts of the body that harbor epidermal growth factor receptor: the skin, of course, the epidermis, and the gut. So patients with EGFR mutations who are receiving a TKI will frequently have skin reactions. We describe this as a macular-papular rash. Occasionally it looks acneiform, but not always. It's often associated with very dry skin or itchy skin. A number of different interventions have been proposed and have been used. Topical emollients, of course, can help. If the rash looks pustular, particularly if it's on the face, we'll often use topical antibiotics such as clindamycin. And in many cases, we'll prophylax with antibiotics. I'm partial to doxycycline, or occasionally minocycline for 2 weeks on, 2 weeks off, to try to at least mitigate it. These toxicities. You very seldom prevent the side effects, but you can at least make managing the side effects easier. Many of my patients have really learned over time how to deal with the rash, cover it up sufficiently so that it's not truly evident. There is a phenomenon called tachyphylaxis, where over time, the side effects that appear, and they usually occur within a week or two of initiating TKIs, will start to dissipate just on their own without dose adjustment. But frequently, to manage this issue, particularly if it's grade 3 or worse, you need to either lower the dose or interrupt treatment for a week or two. The other major toxicity is diarrhea. 60 to 80% of individuals receiving TKI will have some diarrhea. 10 to 15% will have grade 3, and that is fairly significant diarrhea. We have instructed our patients to take antidiarrheals, Imodium, Lomotil, at the first sign of diarrhea, not to wait. And the package inserts frequently indicate you can take only up to 6 or 8 pills a day. You can easily exceed that amount. The medication really needs to be titrated to the incidence of diarrhea. There are other occasional side effects. Stomatitis can occur. It's relatively rare. It may be a bit more common with afatinib, with the second generation TKI than erlotinib and gefitinib. Over time, the nature of the rash will evolve. The papular pustular rash we see in the face and torso will start to fade, and we'll start seeing more rash on the arms and legs, and particularly the development of pyronychiae and digital fissuring. The latter actually can be taken care of with superglue, which is an interesting application, but just applying superglue over these cuts will prevent them from getting infected and will actually aid their healing. For pyronychiae, we'll use special soaks that include vinegar and antibacterials and antifungals. So a relatively rare side effect that occurs on occasion seems to be a little bit more common in the East Asian population. It's interstitial lung disease. So we have seen the development sometimes of fairly florid interstitial pneumonia. It'll be heralded by shortness of breath and cough, frequently by hypoxia. So if the pulse ox is dropping, that's an immediate indication to halt the TKI. That side effect will generally respond to steroids. I will treat those folks with the same dose of steroids I'd use with radiation pneumonitis, and for the most part, that toxicity resolves fairly quickly. But it will certainly give you pause in considering whether to resume TKI. And that's the one group where I will probably not resume the agent, or I'll think twice about it. Whereas with diarrhea, with skin rash, it's a constant reassessment and negotiation of how to manage the individual. I think it's important to